Let us start our session. Please, can we call for Dr. Brooks? Dr. Brooks. Dr. Brooks will speak about AVM management and how I do it.
Well, good afternoon, everybody. Almost good evening. I think everybody sort of needs praise for their stamina, their strength to keep going. I'm from London, and Professor Radwan and Ashram, we meet at the Charing Cross meeting every April, and it's my pleasure to be here. Thank you very much for inviting me. We're going to talk about AVMs, how I do it. This is more general talk, and I think it's tomorrow I'm going to talk about some of the new stuff as well. So this sort of sets the scene. This is standing on the shoulders of giants. This is John Bland Sutton from the late 19th century, very famous surgeon. He recognized arteriovenous malformations as well, and people have been struggling with them for over 100 years, trying to find sense in what is a very perplexing and confusing subject. And we see these now, and all they could do then was beautiful dissections, but the patients didn't do very well. And as he says here, don't cut into it, because the patient will bleed out. Dreadful things, again, beautiful dissections. They ligated the carotid arteries, the patient stroked and died on the 3rd day. But can we do any better now? Look at this, the lithograph that we were just looking at is mimicked here by a 3D reconstruction CT scan, 1892, 2013. It's the same lesion, but can we do any better? And fortunately, rather than dying on the 2nd day after stroke, yes, we can. What is our current understanding? Which is important because there's a lot of dogma about AVMs, and I'm sorry this is such a busy slide, but this is a mixed bag of problems, and they're not tumors, they are malformations, because traditionally they have been thought to be non-proliferative, which is not true. They're classified based on essentially descriptive parameters, either clinical, genetic, or pathological, and the classification system has developed with our understanding of these lesions and is held by the International Society of Vascular Anomalies that's meeting in Vancouver if you want to come along next year. The main types of malformation depend on the injury to the differentiation, so it can be of a capillary nature, a venous nature, a more lymphatic nature, etc. It's all vascular developmental errors. They're present from before birth, but grow at various stereotypical times during infancy, puberty, pregnancy, and after trauma. And trauma, remember, is also surgery. And we also treat them only when they've become complicated or symptomatic. This is that famous ISVAR classification. Suffice to say, it gets more complex every time it's published, every 2 years. But it's essentially descriptive of a myriad of mostly random lesions, but there is a whole host of interesting familial genetic ones as well. They can manifest anywhere from the skin down to the bone and will present to the appropriate specialists, all of whom have a different take of the same story and adds to the confusion. The presenting features are mostly pain and bleeding, but will also depend on the position of the lesion and whether or not there is occupation of space by the lesion, for instance, problems with airway in the head and neck. Certainly, they all cause in a multidisciplinary clinic, which in truth is vascular surgery and interventional radiology, but sometimes plastic surgeons and sometimes dermatologists will lead the charge. But you have an interested group, you look at all the pictures, you use duplex and MRI, and proceed to angiography where necessary, and also have a close relationship with hematology, because as we've been hearing today, prothrombotic tendencies in a lot of the venous malformations may lead to pulmonary embolism and death in young people. Watch out for the vascular tumor that turns up. It's really a sarcoma, so you've got to see what is and what is a tumor and treat it accordingly. People who've helpfully treated it before, so you're dealing with venously. We've now got newer ways of doing MRI with time-resolved MRI, which is proving very helpful. This is not the greatest example, but it's kind of out of the MRI. And you can use that to guide the angiographic embolosclerotherapy and its successful outcome. So here in a thumb on the MRA, here it is at angiography and following successful treatment. We can classify them according to how it looks, the useful sort of how it looks in order to know what to do. Classification, and this man is Wayne Yates. You're probably familiar with him. He's the sort of grandfather of it all, and he's taught us all his approach to dealing with specifically high flow malformations. And this is his classification, developed from the brain classification of Hubbard. The high flow technique, the idea is to ablate the endothelium succeed in getting to the nidus transarterially, and other times you can come backwards up the vein, but the idea is to ablate this endothelium because that is where the problem lies. Bland occlusion. So some cases as we run out of time. 32-year-old woman with recurrent pulsatile growing lump of her thumb. There it is on MRI, hypothenar eminence. This somebody's already coiled off the ulnar artery. There is the recurrence. Inject it with alcohol, and the follow-up, there it is, obliterated. That's to summarize in a second what we're trying to do here. And there we are 6 months later on the MRI. Has resolved. 45-year-old woman bleeding from her mouth, had her external carotid ligated, and she's now feeding the lesion through her ophthalmic artery. Somebody suggests that I should stick a catheter in that. I don't need to tell you my response. There it is from a lateral. Absolutely horrific, but now guided by that angiogram, we can directly stick into the lesion, trying to find, which I think is up here, the venous transition, and eventually we get there. Just go with me on this. We're injecting and sclerosing, and now it's gone. It's shut down. And so we've eradicated the lesion. So that's the essence of it. I realized with the timing, I was going to do a whole load of stuff about low flow as well, but I won't because we'll run out of time. But here we are, high flow. This one reached transarterially through the maxillary artery, obliterated with a direct injection. And this introverted, wig-wearing, very unhappy girl is now rendered normal. Suffice to say, low-flow lesions are treated by sclerotherapy without the angiography, based on findings that observed 150 years ago that sometimes with inflammation, these lesions will automatically, spontaneously resolve. Any chance of just showing the conclusions slide like everyone else begs you? There are many forms of sclerotherapy agent. I don't think it matters so long as you know your agent. There is a classification for treatment of low-flow malformations that depending on its venous outflow. We use foamed sclerotherapy by the method of Tassari. And we follow them up really clinically, because MRI will always look awful, even when you've treated it. If you look at the MRI, there's always going to be an abnormality left on it. So just an example of a low flow. Here's a type 1 in the back of a woman's neck, injected, and after 2 sessions, for it so often takes 2 or 3 sessions, it's eradicated. That was a simple one. Are they always simple? No. A 35-year-old, I only have his CT on presentation, many previous treatments, was very difficult to treat because it's all around his airway. Suffice to say, he got a great result, which I can't show you. But I'm very happy to show you these outside of here. We'll talk tomorrow about, if you can hang on, can you bear this a little bit longer? It's a good outcome. So we treated him. 10 days later on ITU, looking appalling, and everybody calling the chaplain that he was going to die. They couldn't do a tracheostomy, they said, because it crossed the front of his neck. So we did an image-guided tracheostomy, and we waited for him to recover in the normal way. And at 20 days, he sat up and essentially was cured. And he got back on his bike 6 months later. He's a courier, and he no longer has a swelling low-flow malformation in his neck. Complications. We have to say that this is not a complication. This is just part of the journey. Because if the end result is this good of a high flow of the lip, this cannot be taken as a complication. And our complication rate is now less than 5% for all malformations when we've audited it, our 5-year figures. So we've got an acceptable rate, we've got an acceptable method, we're starting to understand it better. There is a way forward with AV malformations, and the exciting stuff is in the talk tomorrow. Thank you very much.
Thank you, Dr. Brooks.